Yes, thank you, Akhil sir. Very good evening to all of you, and welcome again to this Experts Talk Show. For today's discussion, we have unanswered questions in hypertension for family physicians, and to have the resolution of all our queries, we have none other than a person whose introduction itself can go over one full webinar. So I have to introduce him. I welcome Professor Dr. A. Muruganathan, who is the Chairman AG Hospital, Tirupur, Tamil Nadu. He has been the emeritus professor from the Tamil Nadu Dr. MGR Medical University. He is the present convener of American College of Physicians India chapter. He has been the past dean of Indian College of Physicians, past dean of IMA CGP. He has also been a past president of one of the most prestigious association, that is Association of Physicians of India. He has also been a past president of Tamil Nadu chapter of IMA. He is also past president of Hypertension Society of India. He has been editor of innumerable books, including Manual of Hypertension released in 2015 and 2019. He has been the recipient of Dr. B.C. Roy Award in 2005. He's also been the recipient of Lifetime Achievement Award by various organizations, including Dr. MGR Medical University. His abilities as a teacher, as an organizer, is beyond comparison. We have witnessed when he had done a conference called as Epicon, which is a mammoth conference, to hold it in a place like Coimbatore, which is unbelievable. People could not believe it, sir can do it. And another story I will tell it, sir in his tenure as a Dean ICP had released so many books and had come out with so many scientific modules which were far excellent. So we welcome you, sir, for IMA Mumbai West for this program, sir. So friends, today what we are going to discuss about is unanswered questions in hypertension, and I will ask sir, we have been seeing there is an increased prevalence of hypertension in younger population, which we are seeing in India. So what do you think, what is the contributing factor, reasons behind it?
Okay, thank you very much, Dr. Ketan Mehta, for this opportunity. I'm very happy to meet and connect our IMA people of Mumbai West. I had been there 2-3 times earlier also, and I have got a lot of friends like Ketan in Mumbai West. So Dr. Lile also, I think, belongs to your IMA.
Yes.
Yeah. So I think today is a very happy day for me, in the sense it's a teacher's day. So I'm a teacher. At the same time, I have many teachers also. So it's a good day to talk to people who are very friendly to us. Now, the unanswered questions of hypertension. I'm glad you have chosen this topic. There are so many questions are unanswered in hypertension. So I don't know how much I can answer, but still, it's a very interesting topic. I'm glad people are taking interest in hypertension. You see, I always have a feeling people give more importance to diabetes, not hypertension. I always have a grievance. Hypertension, prevalence, morbidity, mortality, incidence are 3 times more than diabetes. Even a diabetic patient develops problem only because of hypertension. But unfortunately, we have more diabetologists all over the country, all over the world, especially India. Nook and corner, you get diabetologists. But you cannot find one hypertension specialist even in the major city. So my focus for the last 4 years is, to make people interested in hypertension, and make sure you start hypertension clinic. You make sure you get Institute of Hypertension and Hypertension Excellence Center. So I'm glad that you have chosen this topic. Now go ahead with your questions, Ketan.
Yeah. So, sir, we are seeing the increased prevalence of hypertension at young age.
Yeah, we're talking about age. Yes. Okay.
Yeah.
Whenever any young person comes to you with hypertension, first you rule out secondary hypertension. This secondary hypertension is one which you can get either in the younger age or in an extremely older age. So rule out secondary hypertension. Then in this era, especially the modern era, people are very much interested in software. So IT people. So I think it is called IT hypertension, because many people, especially adolescent boys and girls, day and night they work, they overwork, and their food habit, really fast food. I always tell fast food takes you faster to the grave, and then hurry burry, and all these social determinants of health, all these things, are the main causes of hypertension. So if they can relax, if they can, understand how to relax, and if they can do meditation, and then take care of their health, which is very important. So as I said, first I will rule out secondary hypertension, then I will advise them lifestyle modification. That is a key for the youngsters. And I agree, a lot of people now developing hypertension, and many of them may not even aware that they have hypertension. So that is why even in younger age, I promote home blood pressure monitoring so that they can do check the blood pressure periodically. Yes, Ketan.
Okay, so you have now opened the Pandora's box, which you have said about home monitoring of blood pressure and all. So, sir, before we come to that, you mentioned about ruling out hypertension. So, is there a particular age beyond which you would look out for secondary cause of hypertension? The good old teaching when we were there as students, so it was like, that if there is a family history, you can still get it at the age of 40. So now, is there any particular age beyond which you think now this should be investigated for secondary hypertension?
Actually, the extreme old age and younger age, for example, below 30 years, somebody has got high blood pressure. They're coming for the first time. You check the pressure. The pressure is something like 170, 100, or 110. Immediately, you should think and then rule out secondary hypertension. You can ask questions like whether he has got pain, palpitation, sweating, whether he has got any other problem. And then you see there are so many causes of hypertension in the younger group. Probably kidney disease, chronic kidney disease, coarctation of aorta, and then endocrine disorders. So you try to ask those history relevant to that. And then again, one more thing, youngsters also now they take alcohol and smoking. So that also they should stop. And they must also find out whether you are taking any drug history, because some people are taking drugs which we do not know. That also can produce even nasal decongestants. If you are taking continuously, and if you're taking some weight reduction or drugs which we don't know, those drugs also can produce NSAIDs. If you take continuously for pain, some NSAIDs, that also can produce hypertension, secondary hypertension. So rule out by history taking, those things are not there, then you can investigate. Yes.
Right. So very nice point which you have brought, and which is in reality that many a times, patient who is not a hypertensive comes out and detect to be hypertension. Then we realize last few days they've been continuously taking NSAIDs, and that is how their pressures are increased. So history becomes a very, very crucial part when we are looking into it. So, sir, you mentioned about home monitoring of blood pressure, and now obviously all the recommendations are changing. The concept is changing from office BP measurement to the home monitoring. So would you recommend each and every hypertensive who has been labeled should go and, like now glucometers we have been promoting for diabetic patients. So will this become a day-to-day utility gadget for a hypertensive patient, sir?
Yes. Even many international guidelines, the American Task Force, the Canadian guidelines, all the guidelines say you should not diagnose anybody as hypertensive unless you do out of office BP measurement, either with home blood pressure monitoring or ambulatory blood pressure monitoring. By which we mean somebody comes to you, you check the blood pressure. According to the new guidelines, if somebody has got more than 140 systolic and 90 diastolic, you think that they have hypertension. Don't jump into conclusion. You make sure that they do home blood pressure at the home BP monitoring at home, and also if possible ambulatory blood pressure monitoring. And still if they have 149, more than 140/90, then you label them as hypertension. So to diagnose, it is a must that home blood pressure monitoring, and also to follow up. See, home blood pressure monitoring is two major indications: screening, diagnosis, and follow-up. Screening, why I say screening, because I give an example. One of my patients had a high blood pressure, and I advised the home BP monitor. For fun, that person's wife, tried. His wife also had home blood pressure, BP more, and his sambandhi came to home. They did the check for there. There also the BP was going. So it is also useful in screening people and then getting them. Once this they have high BP, they come to the doctor. And another interesting anecdote I have to tell you, Ketan, one of my patients, a lady patient who is a vegetable vendor, I trained and taught about the home blood pressure monitoring. She not only does for her, she takes it to the market, the vegetable market, she keeps it. Whenever somebody comes and if she has lesser time, she checks the blood pressure for the customers who are buying vegetables. So she got getting better, sales. And now I heard she's charging 10 rupees extra for checking the blood pressure also. So blood pressure monitoring becomes very, very useful. Nowadays, everybody knows, even a village person, they're using mobile phone. When they can use the mobile phone, easily they can use home blood pressure monitoring. The drive home message here, I request all our practitioners promote home blood pressure monitoring. In India, the home blood pressure monitoring incidence is less compared to home blood sugar monitoring. Home blood sugar monitoring, when you do, you have to prick, and every time you have to take a strip, which may cost 15-20 rupees. Whereas home blood pressure monitoring, nothing. You don't lose anything. And that is the easy way to diagnose. Also, you can spread the awareness. So my message is, please promote home blood pressure monitoring. I've written articles and many places. What I always tell my doctor friends and non-doctor friends, whenever you go to a wedding anniversary or birthday anniversary or 60th anniversary, don't buy any gifts. Buy only home blood pressure monitoring. Give that gift to the family. The whole family can use it, so that they will lifelong they'll remember you. So blood pressure monitor is the best gift for all the people, all the ages. Yes,
that's a fantastic message, sir, you've given and promoting about the home monitoring of blood pressure. And as you said, because in certain times we used to see there were vendors who were keeping weighing scale and people were paying, or on railway tracks, railway stations also sometimes those weighing scales are there. So probably the time has come where there could be this BP instrument machines which are kept, and with whatever charges it can be measured. So it will be a mass screening which can be done. And since our country is really seeing a large burden of hypertension in population, so very good message here, sir, you said.
One more thing, because you said home blood pressure monitoring, I'll give you one more, because I'm very passionate in talking about home blood pressure monitoring. Home blood pressure monitoring is not only home blood pressure, beyond home. You can keep it in the library, you can keep it in the salon, barber shop, railway station, bus station, malls, especially in the entrance of the mall. All the poor husbands will be waiting in the mall when their wives are shopping. His BP will go up. So check the pressure beyond home. So home blood pressure monitoring beyond home also is possible. And I think that's a good thing you have asked me. This is what you have to promote now, please.
Absolutely. And second thing is, as opposed to glucometer, it is just a one-time investment. There is no recurring cost. You can check as many measurements if you want. Yes. So that's a fantastic message. Yes. Sir, you mentioned about ABPM also. So now how do you place, where is the requirement for which subset of patients ambulatory blood pressure monitoring is of use?
Okay. Ambulatory blood pressure monitoring is the gold standard for diagnosis and also follow-up to titrate the dose to see the complication. In a diabetic patient, in my experience and in my practice, I do ambulatory blood pressure monitoring for a diabetic patient at least once a year, because you cannot diagnose nocturnal hypertension. In a normal circadian rhythm, everybody has got ups and downs. When I talk, my BP goes up. When I'm sleeping, BP comes down. When I'm with my wife, BP may be normal. When I fight with somebody, BP may go up. So the BP variability is there. To find out the BP variability, as well as normally there is a normal dip. We call it a nocturnal dip. Every normal human being, when they sleep in the night time, the blood pressure drops. And early morning, the BP goes up. It's called early morning surge. In a diabetic patient, there is no normal dip. Instead of normal dip, there is a hypertension. So we call it as nocturnal hypertension. And also, in the early morning surge will be more. So these are the two culprits which produces CVA and the cardiac problem. So ambulatory blood pressure monitoring is a very useful tool to diagnose BP variability in the drug importance, especially when they have autonomic neuropathy. We can always find various types of BP and various postures also. Unfortunately, the ABBM is very cumbersome, so people may not like it. There are some instruments that are coming which is patient friendly, which you can wear it in wrist also. That does not come. And incidentally, a diabetic patient at least once a year they should undergo to find out nocturnal hypertension. If they have a nocturnal hypertension and early morning surge, you can titrate the dose. Instead of morning, you can give in the night so that you can titrate diabetic, the early morning surge. And also, what is known as, extreme dippers. Sometimes the people are extreme dippers. They'll have more fall in the dip, and then early morning surge will be more. So suppose if they have dip of 80 systolic and their blood pressure in the morning is 140. So from 80 to 140, 60 millimeter more. So that means early morning surge. Even that cannot produce problems. Yes.
Okay. So that's again a very good message, sir, is given that for a diabetic population who are also hypertensive, once in a year ABPM, which would definitely, we can pick up the patients who are at risk for a vascular event, which are common in the night hours or early morning hours. So we can pick up those patients also over there. So now coming to the most crucial part, sir, in last 2-3 years, the various guidelines has given different cutoff and created a lot of confusion amongst the practitioners. We have seen the ACC-AHA guideline, which reduced the level so drastically after the sprint trial, and they came out the cutoff as 120/80, whereas European Society still believes at a higher one. And last year, our own Indian guidelines on hypertension, you were also part of it, which came out in 2019. So will you give a message for our doctor friends that what guidelines they should believe and what should be the cutoff, where they would label it as hypertensive? Because there is a lot of confusion which is happening.
Yeah. Guidelines are only guidelines, not guidelines. So don't go with the guidelines alone. The American College, ACC has given 130/80. The European 140/90. The recent guidelines, International Hypertension Society guidelines was 130/85. And then our guidelines 140/90. Doesn't matter. Whatever the definition they give, the important message is it is always better to keep the target or the goal 130/80 and around that. You should not, in a hypertensive patient, if they can achieve 130/80 and if the patient can tolerate even little lower than that, you maintain that dose. So the goal is 130/80. Especially South Asian is an extra risk. And when they have a cardiovascular risk, when the Framingham score and when the risk scores are more, it is always ideal to keep the blood pressure at 130/80. So forget about any guideline. If somebody has got hypertension and if you can achieve 130/80 without compromising the quality of the patient, without producing any problem for the patient, that is the ideal goal, around 130/80. When I say 130/80, it can be 124 to 130 or 132 also. 80 means 80 to 82. So around that area, 130/80, if you can maintain the goal, nothing like that. So don't worry about any guidelines. Your target or goal should be 130/80, especially if you have a comorbid conditions like diabetes or kidney disease, or cardiovascular problem. 130/80 will be ideal, especially South Asian, who's an extra risk when compared to the other country.
Yeah, so that's a very good message, that don't just look at what the initial BP is. More important to reach the target, and that is what we should be looking at it. So that's a very crucial point. We should be looking at it, and we should try and achieve this. So sir, now somebody who has been diagnosed, say for on home monitoring, his sugars, his pressures are remaining always on a higher side, and he comes you, and he is symptomatic in terms of sometimes giddiness and headache, heaviness. And so at the point of starting therapy, what are the routine set of investigations would you ask for when you are starting the therapies?
Okay, when somebody comes with, let us say, high normal or BP of 140/90, even if they get high normal, according to the other guidelines, if they're having the 130 to 139 and 80 to 89 diastolic, then they call it as high normal, some of our guidelines. So even if they come above 130/80, I always put them on intense lifestyle modification. Irrespective of whether they are going for 140/90, whenever they come, I tell them, please go for lifestyle modification. Lifestyle modification number one, I tell them, they, because of the hurry, hot curry and worry, they don't have peace of mind. Ask them to relax, yoga, then do normal things. For example, if they want to go to temple, don't go by car, go by walk. You will get extra punyam if you go by walk. And if you have to climb 3 stairs, don't go by lift, walk. If you have to go to shop, you go by walk. So thereby you force yourself to lifestyle modification. And number two, I always say lifestyle modification in my own style, it is wife style modification. Wife. Why wife? Because in a family, wife only decides many things, including the food what you are going to eat. So if wife decides, and if your wife knows that this man is going to be having problem, she will reduce the salt, because salt is very important when you, especially diabetic, they are salt sensitive. So you will have to reduce salt in all your food, and then you must take DASH diet. DASH diet is diet for the to stop this hypertension. That diet advice is you take 3 to 4 times or 4 servings of vegetables and fruits. None of us take vegetables that way. So if the wife understands, she can do, and she can also do a healthy diet, and she will make you also walk. If you are not walking, she'll say, "Let us go for a walk." So you take her walking, especially in Mumbai. You have got enough place, beach, and all that you can walk. Otherwise, you can take your dog for a walk. So lifestyle modification is a must, and you do it daily. When I was a young PG, even now I'm young, but when I was a young PG, my chief used to ask me to go to the 4th floor, 5th floor only by stairs. He won't allow me to go by lift. So like that, you start practicing lifestyle modification, number one. Once okay. Then next stage, even after lifestyle modification, we give them 3 months intensive lifestyle modification. If they still have, then now the teaching is, especially the international guidelines, European guidelines say, you start them on combination therapy and start with 2 drugs. And it's very interesting. We used to start only 1 drug, and then we use only at stage 2 hypertension, we give 2 drugs. So first of all, when you come, you diagnose hypertension, 3 times you verify. Also give a home blood pressure monitoring, recheck. And once you are convinced that is hypertension, according to new guidelines, they say you can start on 2 drugs. Of course, you can start on 1 drug also, single drug. Monotherapy also can do. But what the other guidelines say, I tell you. The international guidelines, the European guidelines, what they say, for example, amlodipine 5 milligram, telmisartan 40 milligram. These 2 becomes a 1 tablet. This combination pill, they give first visit half tablet. Half tablet contains 2.5 milligram of amlodipine and 20 milligram of telmisartan. The patient goes home and then comes back after a month. Still the BP is not under control. Half tablet is converted into 1 tablet. Okay, again they come back. If the pressure is not under control, they give 2 tablets. 2 tablets contains amlodipine 10 milligram and telmisartan 80 milligram. So like that they do. Why? Because adherence is good, compliance is good, patient understands better. So that's why these people advise combination therapy, and this simple way. This is called simplified protocols. WHO also says simplified protocols. In fact, I came and spoke about this in Mumbai West sometime back in the vital strategy, save lives. That project I came and spoke. So simplified protocols is easy because all the 365 days, the drug availability is there. The problem with the public health and government hospital, today they give 1 drug, after 1 month they give the different drug. So there is no continuity. So now the government of Maharashtra and other governments, they've taken this policy of simplified protocols. They give this drug throughout the year, so that easy. And the drugs like amlodipine very cheap, so you can start. And then when you combine amlodipine and telmisartan, the edema also is not there. What is the side effect for amlodipine will be countered by the ARBs. So like that, the simplified protocols we do. In a private practice, if you are very confident, you can start them on a single therapy depending on the age and comorbidity. You cannot say generalize. You give me ACE inhibitor, you give ARB, you give amlodipine, you give beta blocker. You cannot say that. Depending on the age, depending on the sex, depending on their comorbidity, we advise them. For example, you are talking NSAID. If somebody has got NSAID and then hypertension, the best drug is amlodipine. When a young lady comes, you cannot give ACE and ARB because she may go for pregnancy, reproducible age. ACE and ARB are not indicated in pregnancy. And somebody comes with over sympathetic activity and they are very nervous, you start them on beta blocker. And if they are old patients with diabetes, better to give CCB. So there's a single therapy, monotherapy, we can start like this. And even I told you, you have given a beautiful point. clinical examination and history also very important in hypertension. We think only checking the blood pressure and leaving. No, you will have to do inspection, palpation, and then auscultation. When you see the patient, you will know. When you shake hand, first of all, you shake hand. Now we don't do the shake hand because of corona. When you shake hand, you can see their palm is very sweaty. That means this fellow is got sympathetic overactivity. And when you shake hand, if the hands are shaking, he's got hyperthyroidism, secondary hypertension. So by doing every inspection very properly and asking very good pertinent history, then you can decide what the type of treatment you give. And these are the drugs which you can do. There are 4 drugs which normally we start giving: ACE, ARB, then calcium channel blocker, and then diuretic. In the many guidelines, they don't say beta blocker. The beta blocker is not a first line drug. These 4 are the first line drug. But in India, we still use beta blocker. For example, in a young patient who is nervous, who is sympathetic overactivity, we give them beta blocker. And a lady, pregnant lady, we give them only beta blocker, labetalol. So depending on the age, condition, comorbidity, and then you can individualize. More than that, your expertise, because many people are practicing for so long, they know what is good and individualize and customize the treatment. The general guidelines, what I said, is okay for everybody. Yes.
Right. So you have very nicely summarized about the initiation of the management for hypertension. And now again, the very crucial point which you have mentioned about the beta blockers. Now we have witnessed, sir, though the international guidelines, which had not included, especially from the Western world, except the NICE guidelines, which included beta blockers, which is as a second best option also after in a younger patient. But somehow, sir, we all Indians have used left, right, and center beta blockers as antihypertensive without any other compelling indications. And we have seen excellent results. So how do you take, sir? You have used, or how is your experience with beta blockers as a monotherapy in hypertension?
I agree with you, because we had been using beta blocker from our early age, and we still find beta blockers are very useful. It is not like, it's one day it's going to be out of market. See, the problem with the beta blocker was, you cannot use it for certain conditions. Like if you are an asthmatic, if you are a diabetic, if you have a depression, if you are having a younger age for fear of erectile dysfunction, all those things you consider and then you don't do. But when a person has got palpitation, sympathetic overactivity, and if there is no other contraindication, still beta blocker is good. But you cannot stop beta blocker in a person who's got cardiovascular problem. If they got angina, if they got cardiac failure, and if the lady is pregnant, you don't have any other option except to give beta blocker. So beta blocker still we can give, but not as a first line. Depending on the condition, we can give. And especially in cardiovascular problems, we cannot help without giving beta blocker. In cardiac failure, angina, and infarction, beta blocker still holds good. And if somebody has got migraine, headache, and BP, sometimes we switch over to beta blocker because that reduces migraine also. Yes, please.
So here another point, sir, which we see is the checking the pulse also. Somebody who has got a oversympathetic drive, whose pulse rate is 90, 95 and all. So would you think these are the patients who would be better off by giving a beta blocker therapy, without any compelling indication?
Yeah. In my practice, I do that because, when you see somebody is having a sympathetic overactivity, it's always better to reduce the heart rate, because the more you bring it to the level of 70 or 60 to 70, the longevity and the cardiac problem will be always normal. So I think there's no harm in giving a beta blocker, provided there is no contraindication for the beta blocker. Otherwise, you can give. Now there are two, three good newer beta blockers like bisoprolol, then carvedilol, and nebivolol. They're all very good. They got. Unfortunately, we don't have a big study for these things, but still, when you use in practice, I think it is very good. So still, beta blocker can be given, and if there is no improvement in when you give 2 drugs, sometimes you'll have to add beta blocker, and that may work well compared to other drugs.
Right, right. That is so. Only initially, what the propranolol was there, which was a non-selective cardiac drug, and now, of course, nobody uses propranolol as an antihypertensive per se, which was used. So, no, as we said, the newer beta blockers, which really works good in specific situation. Okay, sir. Coming to RAS blockade therapy. Now, you have a two major class you mentioned about AC inhibitor and ARB. So now, where do we choose? If it is a only antihypertensive therapy and if you want to give a RAS blockade, would you like to choose ACE inhibitor or ARB?
Again, the trials, the evidence are more favor of ACE inhibitor because ACE has got more trials and it has got cardiac protection, renal protection, and it is a very good drug. Compared to ARB, ARB is also equally good. You know, on target trial, what it proves is ramipril and the telmisartan. They say telmisartan is not non-inferior to ramipril. So non-inferior to ramipril means it is also equal. So the evidence says ACE inhibitor, but problem is ACE inhibitor has got more side effects like cough, angioneurotic edema. So we don't give ACE inhibitor for some people. As a antihypertensive, in my opinion, the ARBs are better antihypertensive than the ACE inhibitor. But cardiac protection, neural protection, renal protection is more in the ACE inhibitor. So somebody is not having any side effect with ACE inhibitor, and if they have got cardiac problem or renal problem, we still go for ACE inhibitor. If you want use as an antihypertensive, we can use ARB. ARB is still good. So ARB on par, not below, but unfortunately not many trials to prove the cardiac outcome trials for like HOPE trial. We don't have that many trials for ARB, but still on target trial prove ARB is non-inferior to ramipril.
Absolutely. So that's a very valid point, and I think all my other colleagues would agree that we have definitely got a little better experience with ARB when we are using as antihypertensive. But obviously, with a compelling indication with underlying cardiac issues, obviously ACE inhibitor who has got a little more pronounced data for cardiac safety and efficacy, then obviously ACE inhibitor will be your choice. Okay, sir. Now, another drug you mentioned about the diuretics. Somehow the diuretics usage in our country is little less compared to what the West is using it. And maybe because the place like yours in Tamil Nadu or in Mumbai with the temperate climates, we have seen the issues with the postural hypotension and all of that. So now in today's time, where do you place diuretics and which one out of diuretics will you prefer as antihypertensive?
Good question. We don't start anybody on diuretic as a first drug in our country, especially in our setup. Because somebody comes, we can start 2.5 milligram of amlodipine. We don't start somebody with 12.5 milligram of chlorthalidone. Because, we always prefer the monotherapy, non-diuretic. Diuretic comes as a combination. It is a very good combination drug. For example, if you give ACE inhibitor for black people, it doesn't work. It doesn't work means, the efficacy is not that good. If you give ACE inhibitor with a diuretic, even for the black people, it works. And somebody has got hyperkalemia because of ACE inhibitor, you combine with diuretic, that hyperkalemia of ACE inhibitor and hypokalemia of the diuretic compensates. So combination, it works. And elderly people, especially isolated systolic hypertension, this diuretic is very good. And accomplished trial, you saw lisinopril, amlodipine, and the chlorthalidone combination. They found chlorthalidone is equally a very good anti-hypertensive drug. It reduces same value as amlodipine. So as an anti-hypertensive drug is good. Chlorthalidone I prefer because it has got polymorphism, polyfill activity. It's a long acting, and with a small dose, it doesn't produce any diabetes. Because we were worried when we give diuretic, it may cause diabetic, and it is also lipid neutral. Lipid not neutral. Lipid, it's against when you get somebody has got hyperlipidemia. It's always better to give ACE inhibitor than diuretic because it is not lipid friendly. Even all the beta blockers, except carvedilol, insulin resistant. So depending on dyslipidemia somebody has, you must choose the drug. But we found in our experience, chlorthalidone doesn't produce much alteration in lipid level. If you have a diabetic hypertension, and especially in the elderly, indapamide is the best drug for an elderly person. For other persons, normally when you want to combine diuretic, chlorothalidone becomes good because chlorothalidone has got many studies, and it is also in a lower dose doesn't cause much symptoms. It is as effective as antihypertensive of other compared to other drugs, which is proved in the trials.
Right. So the issue commonly what we see in elderly patients who are on diuretic, quite often they'll end up with metabolic encephalopathy secondary to hyponatremia, which we have seen over a period of time, because those who have not been monitored suddenly. So if what will be your message if somebody who develops significant hyponatremia on a diuretic, should they be withdrawn from diuretic? Can they be put again once they come out of that phase, or you would like to refrain from using diuretic in those patients?
There are a lot of studies about diuretic preventing stroke and post-stroke also they give, especially elderly. And elderly persons, some people who are very over-enthusiastic, they start salt restriction too much and they go in a summer with the diuretic, they only develop hyponatremia. Not everybody develops hyponatremia. Only people who are overcautious, when they take very much salt restriction, and then in summer it may produce problem. And depending on individual case, I may decide, and it also shared decision with the patient. Certain times, we cannot generalize. We can say, okay, we has got hyponatremia. Maybe hyponatremia may be due to many causes. He may have a renal problem, and that may be causing hyponatremia. And we will have to analyze and then see. And in a renal problem, especially when the eGFR is more than 30, diuretics will be good. If the eGFR is less than 30, we use furosemide. So depending on the individual, it is not like, one just say, this is the general rule. Individual, comorbidity, and then according to the situation and the age, we can do. And diuretic is still a good drug. I always use as a combination drug, not as a single drug. Of course, when there is no other alternative, we do. In US and UK and all, they do ACE inhibitor and diuretic as a first combination. We use calcium channel blocker and ARB as a first combination. But they use ACE inhibitor and diuretic. And for blacks also, ACE inhibitor and diuretic becomes a first combination for them to, it's better for them to act. Yes.
Right. Secondly, sir, you mentioned about the combination therapy in hypertension, and in quite a few number of patients where we have to initiate directly with combination. So what do you prefer, sir, as a fixed dose combination versus two separate pills? And when you would recommend to take it in the morning time or evening time, if it is a fixed dose combination?
In fact, again, fixed dose combination is easy for adherence and compatibility and the cheap and all that. But I personally, I don't do, this is my opinion, my experience. Guidelines say you give fixed dose combination is better than the separate drugs. I prefer separate because if somebody has got blood pressure in the morning, say 160 or 110, night also 180, 110, then you have to, though it is a 24-hour drug, any drug like amlodipine and telmisartan, it is 24-hour drug, but still we prefer to give one nighttime dose because ADA also recommended you give one drug in the night so that you can prevent early morning surge. That is how the ambulatory blood pressure comes into very useful. And you see somebody has got nocturnal hypertension and they got early morning surge, it is better to give them nighttime if you are having two different drugs. If you are giving a single drug, single combination, again depends. Suppose if you are giving a diuretic combination, no point in giving diuretic in the night because it will disturb the patient. So give him in the morning. And if you are giving a beta blocker as a combination of drug, it is better to give in the morning only, not in the night. But if you give amlodipine and telmisartan, you can give both night and day because I see recently 2-3 evidence and guidelines say you give them in the night because ROS is very active in the night and people develop edema, so better give in the night. So don't give in the morning. That's somebody said. But the Kaplan in the first edition or second edition, he was saying you start giving them before they go to urine or bathroom in the morning, early morning. As a drug. So again, it all depends on your experience, depends on the condition. Both the ways it's okay because if you say telmisartan or amlodipine, both are long acting. So one you do in the morning, one in the night. There was a debate. Amlodipine should be given in the morning. Telmisartan should be given in the night because telmisartan RAS activity it prevents. amlodipine, it will be given in the morning. Again, depends on your experience and your takeoff. And both the ways is good, but I prefer a single alag because combination sometimes you cannot titrate. Number two, I feel it may not be covering the actual nighttime pressure, so we give that way. Again, depends. And then the combination can be beta blocker, or it can be diuretic, it can be AS or ARB and calcium channel blocker. So depending on the combination, you can do according to the individual and situation.
Yeah, so that's a very good message you have given, that for titration purpose, if the two separate molecules are there separately, that would be easy to titrate. But when the patient compliance is compromised, then obviously it is better to give a fixed dose combination. So individual therapy needs to be decided by the clinician when they are selecting what sort of patient's profile it is, and that would be cautious. So here's the next. I would like to ask a rapid fire round where I would ask what will be your preferred antihypertensive class in following conditions. So with certain conditions, somebody who has a comorbid condition,
yes,
and what will be your preferred drug? So let's go rapidly over this. So each patient with hypertension with comorbid condition.
okay, sure.
So somebody with unstable angina, sir, preferred class.
Beta blocker.
Okay. Somebody in a post myocardial infarction state.
Beta blocker and ACE inhibitor.
Okay. Somebody with diabetes.
Calcium channel blocker. And then ARB.
Okay. Some CCA for LV dysfunction.
Diuretic and ACE inhibitor. And beta blocker also. Beta blocker also. Or beta blocker.
Correct. Okay. With obstructive airway disease, maybe COPD or asthma.
Definitely no beta blocker, calcium channel blocker.
Yeah, so that's a very crucial point. Sir was saying it is sometimes it is not always the certain selection of drugs, but the certain drugs which need to, or we need to be careful to avoid them. So that was important point. For CKD, sir. So CKD, early CKD and late CKD, both.
ACE and ARB are very good for CKD, but there is a caveat. If the creatinine or eGFR level goes 30% above the baseline, then you may think of giving different drug, not ACE ARB, because there is again controversy. But ACE and ARB in a pre-CKD, it's a good drug. And then after the creatinine is more, then you can think about other group of drugs. Otherwise, ACE and ARB is very good. Diuretic can be given also.
And this is the always common issue. Whenever we start ACE or ARB in CKD, whenever nephrologist sees the patient, if we have not given them, they will start ACE or ARB. And when we have already given, they will knock off ACE or ARB. And that is how they always play around with it.
And if you start them on amlodipine, they will change it to cilnidipine. Because cilnidipine, they feel that's better drug than amlodipine. In nephrologist's point of view, because it's both channel compared to amlodipine. So it's all individual's choice, but still the important message is we don't know what you do, but make sure the numbers are reduced. Whether it's ARB, beta blocker, the one of the article which came very recently said, don't worry about group of drugs. You make sure you attain the target, your number, you achieve the target, your goal. So as per the patients, as per your choice, you can definitely start them on the drugs.
Correct. So that is, we know that there are certain class of drugs which will work better in one subset of patients, whereas another subset of patients, we may have to select a different class of drug with the similar background also. Okay, so continuity to that only. Now, patient with underlying peripheral arterial disease, any particular choice?
Peripheral arterial disease is better to give calcium channel blocker. No blocker.
Correct. Post cerebrovascular accident.
Post cerebrovascular accident, we give normally ACE inhibitor or ARB and diuretic.
Okay. In thyroid dysfunction.
Thyroid dysfunction also calcium channel blocker will be good. If there is hyperthyroidism, if there is too much of tremor and all that, beta blockers also can be given.
Okay. Somebody with hyperuricemia.
Hyperuricemia, the best drug is losartan. ARB is better. You can give losartan.
And diuretics we should avoid giving
Yeah,
them as
that
antihypertensive.
can precipitate gout and then yeah.
Somebody who has a depression.
Depression, any drug can be given, but avoid beta blocker because you got raised a good point. Now in hypertension, when I say cerebrovascular problem, they always think cerebrovascular accident, hemorrhage, and all that. You should not forget in hypertension, one of the complications of central nervous system is depression. So hypertension can cause depression. So any drug can be given except beta blocker.
Okay.
And that should not also be very costly because that will cause more depression. So if you give the costly drug, so it's better you give a drug which comprehensively. Yes.
Yeah, that's a very valid point because in today's time you have a drug which is available at 1 rupee a tablet, and there are drugs which are available at 15 rupees a tablet also. And somebody who has to take a lifelong medication or anything, we need to really look into the patient's pocket, and that would select because he should able to really afford that, and that should not be a burden to it. That's a very good message sir is given over here.
Also, you must look at the patient's attitude. See, recently I gave a amlodipine for a really rich person. It was very cheap, amlodipine very cheap. He was not happy. He went to some other corporate hospital. They gave him some costly drug. He said after the drug only it start working. So depends on the patient also. So the cost is very important for the normal people. For a rich person, when they come, then the attitude you notice and then give accordingly. Otherwise, you lose the patient. Your practice. He'll go to some other doctor, not you.
Yeah, that's a good point. Okay, somebody who has a volume overload state.
Volume overload state, definitely you should give diuretics and
and in a very elderly population.
Elderly population, calcium channel blocker and diuretic.
Okay. So, sir, can you mention now how we see this isolated systolic hypertension, since we mentioned about the elderly population? So usually, again, the class of the drugs should be used in this isolated systolic hypertension.
Yeah, isolated systolic hypertension is not a normal disease because we thought, isolated those days it's not very harmful, but it's very harmful. So especially in elderly, you must see how do you define isolated systolic hypertension? The person has got more systolic pressure and diastolic is normal or less than normal. In that case, what is the important thing is in isolated systolic hypertension, the person will have pulse pressure, wide pulse pressure. Anybody who has got wide pulse pressure, they are more dangerous. You see, if you ask me what is the hypertension which is bad, the systolic is more, diastolic is very low, the pulse pressure is more, that person's problem is more. So if you say whether isolated systolic pressure is more, dangerous or this one, anybody who has got wide variation between systolic and diastolic, those patients are more dangerous, and for them we give calcium channel blocker and diuretic. Similarly, like isolated systolic hypertension, if somebody develops isolated diastolic pressure at the age of 65, you think of secondary hypertension, it can be due to renal artery stenosis, renal artery atherosclerosis. There are two types of renal artery stenosis. One is fibromuscular dysplasia in younger people. In older people, renal artery stenosis is due to atherosclerosis. There, you get isolated diastolic hypertension. In younger people, isolated diastolic hypertension may be there, but in older people, isolated diastolic, you think about secondary hypertension. Yes.
Okay, so that's a very good message which you gave about, think of a secondary cause in a elderly person if you are seeing isolated diastolic hypertension, because that needs to be kept in mind. So, sir, in continuity to that, now when do you label somebody as a resistant hypertension?
Resistant hypertension is defined as somebody takes 3 drugs in adequate dose, and one of the 3 drugs is diuretic.
Oh.
So you give 3 drugs, and one of them should be diuretic. You should not give only half dose. Optimal dose of 3 drugs. Still, if the blood pressure is not controlled, then you call it as a resistant hypertension. Before that, there is a caveat. You must find out whether the patient is adherent to the drug. You give 3 drugs, and they come pressure is more. You think it's resistant. No, sometimes they may not have taken the drug. So you rule out pseudo resistance and then confirm it's resistant hypertension. Then you give these 3 drugs. There is one more entity called refractory hypertension. There you give 5 drugs, but still it's not controlled. It's called refractory hypertension. And if somebody has taking 4 drugs, also it is called resistant hypertension. Yes, please.
Okay.
Sorry.
So in this nomenclature, there are 2 terms which have been commonly used, hypertensive emergencies and hypertensive urgencies. So can you just make the explanation for both?
Anybody who has got blood pressure of 180 to systolic and 110 diastolic, and if they got hypertension mediated organ damage or target organ disease, it is called emergency. Somebody has got high blood pressure, there is no target organ damage, they are called as urgency. So urgency and emergency difference is, if somebody has got 180, 110 with target organ damage, you call them emergency. Somebody without target organ damage, you call urgency. Again, there is another class 2 terminology they use called, those days we use malignant hypertension. Malignant hypertension means the person with papilledema with 180, 120. And when he has got no papilledema, only grade 3 retinal changes, it is called accelerated hypertension. So malignant hypertension, accelerated hypertension, hypertension emergency, hypertension urgency.
Okay. And so the drug of choice for hypertensive emergency, because obviously when it is a hypertensive urgency, these are the patients the doctor should definitely refer them to the hospital. But hypertensive emergency, where patient may not require hospitalization, what will be the drug of choice to start with at that?
You are saying vice versa, ulta. In hypertension urgency, you don't need.
Yeah.
So,
yeah.
Again, in hypertension urgency, you give only oral drugs. You do not give parenteral drug in hypertensive urgency. Whereas in hypertensive emergency, you should give IV drugs only, because you have to reduce the pressure, because he may land up in dissection aneurysm, or in pulmonary edema, or it may be cerebral stroke. So there you will have to reduce the blood pressure very, very fast, and IV is required. Whereas in urgency, you don't require urgency. So you give oral drugs, you can titrate the drug, as I said, 3 drugs, 4 drugs, like that. But in my practice, what I do, even if they have hypertensive urgency, I admit them, because in India, our people, if you say you take home relax, they'll land in problem. And to be on the safe side, keep them under a hospital, observe, and then give them drugs, will be better. Otherwise, they will not take care, and they may land in a lot of problems. So even hypertensive urgency, if they can afford, and if they are not well educated, it is better to admit them, give them oral drugs under your monitor, and can do. If the patient is educated, you can give them home blood pressure monitoring, and then you can do. Nowadays, even telemonitoring is available. So you give the home blood pressure monitoring at home, and you monitor from the hospital, and you can titrate the dose from the hospital only. So urgency, normally we don't need admission, but if the patient is not educated, and if you think he'll go haywire, you admit them, observe them, monitor them, and reduce the pressure.
Yeah. So here's a good old times, the nifedipine, which was used as a sublingual mode, and people are still using it. But in fact, I remember there was an article in British Medical Journal, because of they have started banning globally use of sublingual nifedipine because of sudden precipitation of vascular events, those who have got a cardiovascular or cerebrovascular insufficiency. So probably should we pass the message that people should not use sublingual nifedipine?
Yeah, definitely nobody should use sublingual nifedipine. Nifedipine is very useful, but definitely they should not use sublingual, because more than the effect, there are side effects are more. So it definitely should make sure nobody thinks about sublingual of nifedipine. So I agree with you.
So that's a very important message. Whatever may be the emergency, the sublingual nifedipine should not be used. In fact, we all agree that it has been our teaching when we were students, but then over a period of time, how we have learned and what the evidence coming from various societies, the sublingual nifedipine should not be used over here.
Don't even mention that, because if you mention only, they come to mind. So I don't even mention about sublingual at all. Yes,
that's fantastic, obviously. Yes. So the words don't come out from the mouth what the mind is not thinking, and that you rightly said, sir. So few interesting questions coming from Dr. Durya Desai. Any specific indication for the use of newer drugs like azilsartan or benedipine?
Well, see, azilsartan is another ARB. Though they say it has got long action, and then dissemination from the molecule, it is better. and it is a very good drug for diabetic hypertension. So it's a very good drug, no problem. It's like any other telmisartan. Azilsartan is equal to telmisartan because telmisartan has got time-old trials and all that, so we use still, and telmisartan has got gamma activity also compared to the AT1 blocker, and then PP gamma activity is there, so it is good for diabetic hypertension. Azilsartan is also a good drug. If you are comfortable, you can use that azilsartan. There is no particular advantage or particular disadvantage. Because it's time tested, we use this because we always known devil is better than unknown angel. So telmisartan we give. The other drug what you asked is benidapine. Benidapine is got 3 channel in compared to amlodipine, which has got 1 channel blocking. This 3 channel block, and this benidapine is there from 1970 onwards in Japan. They were using in Japan, and it was there in India. Now it has come back again to India. And benidapine is also a good drug, especially when you think about the patient has got some renal problem, hypertension. It is more friendly to those situations. So benidapine is a good drug. When you cannot give amlodipine, benidapine, the side effects like palpitation, and some people develop a lot of problem, gum swelling and all that in the calcium channel blocker amlodipine. You switch over to benidapine is good. And if you have got albuminuria with hypertension and diabetic, you can give benidapine. So because of the 3 channel, theoretically it's good, and it is a time-tested drug in Japan. It has now come to market in India for the last 3-4 years. That is going well.
Okay, and there is a question from Dr. Ramesh Thakkar. Is there a role of clonidipine or reserpine in today's time?
Yeah, reserpine still some people are using. I don't know, good old drug, but we don't raw wolfia alkaloids, that is reserpine, and they say it has got suicidal tendency and all that. So I don't use, but many old people, they still use the old drug called adalphin acidrex. I don't know, you would have born also. So adalphin, your father must be using adalphin and acidrex. Acidrex is again hydralazine. So adalphin with adalphin acidrex, we used to have Cipla company or some company they use. So of course we don't use that. And clonidine we use for example, in a hypertensive urgency, when other drugs do not act, we add clonidine as a fourth drug or additional drug. Only caveat in clonidine is when you give clonidine, you should not stop abruptly because rebound hypertension may be there. So clonidine is a very good drug, is a reserve drug. We can use it.
Right. So that's a good message. I think there are a lot of comments which has come up about excellent presentations and views and all. My no talk can get over without asking about the role of nutraceuticals. Is there any role of nutraceutical compounds in the management of hypertension?
Definitely, if you are taking nutritious, normal, healthy diet, no role at all. The nutraceuticals, I'm sorry, my friends may be listening. Nutraceuticals, give unnecessarily false promise, especially in this COVID times. I must tell you, the COVID times, lot of nutraceuticals, they are advertising, saying that it will boost the immunity, it will improve the immunity. And for what price? See, if you buy, what do you call that? I don't know, amla in Hindi, amla. It's very cheap. It's, vitamin C. Same amla, you put it in a different nutraceutical format and you give them in prices like, thousands and hundreds. And people go buy thinking that is more nutritious. You buy the natural. When you have a natural food, always go for natural food. What vitamin you get from amla, you cannot get it in the nutraceuticals. And then vitamin B complex, of course, for a vegetarian, if you don't take the good, nutritious, balanced diet, you may take some vitamins. But nutraceuticals, unnecessarily, zinc they promote. They promote selenium. They promote, micronutrients. But the ADA has said there is no role for micronutrients in the diabetes. So nutraceutical, in my opinion, not necessary if you can go for natural. And if you are really interested, go for a good brand, see what is available, see the label, and then go. Sometimes they add some, ingredients which are not good for you. And nowadays, especially COVID times, they add so many things and they give. By the way, in COVID times, home blood pressure monitoring is very good. I have termed terminology called lockdown hypertension. Lockdown hypertension, I introduce a term. What do you mean by lockdown hypertension? Many patients, because of lockdown, they cannot go out, and this hypertension is a silent killer. So nobody has any symptoms. So they don't go out and buy the medicines, number one. Number two, they don't check the blood pressure because they don't know what the pressure is. Number three, they are at home. There is no place for walking or exercise. And then number four, with the wife's and the family's background, they eat and eat, watch TV, and sedentary. So these are the four. And then fifth, more important, anxiety, tension. What will happen? What will happen? Everybody is worried. So all these five factors putting them on hypertension. So I call that as lockdown hypertension. In that lockdown hypertension, home blood pressure monitoring is the key. It will help you. And I'll tell every my patient, do a teleconsultation to the doctor by doing the home blood pressure monitoring. Go and buy the medicines. Medicines are available. Government is allowing you to go out in the morning to buy medicines. So buy 1 month medicine. Don't buy 5 days medicine. Normally our tendency patients, they buy for 5 days, they go to doctor and then only buy the next medicine. Hypertension medicine, lifelong. Buy more. Don't go to the doctor once the medicine is exhausted. Even if the medicine is there, 5 days stock, you go to the doctor. That's another message. Because many people, I'll ask them, why you not purchase? I said, I'm coming today, so I thought after seeing you, I thought you may change the medicine. That is why I did not buy it. So this answer they give. So it's always better to have lifelong medicine. And before medicines are exhausted, you should meet the doctor. I tell doctors, especially the people who are watching, please do a counseling with the doctors. Again, nutraceuticals, you asked me, a very good point to the International Hypertension Guidelines, May 6th it has come. They say hibiscus tea, then pomegranate juice, choco, all are good. It's not any study, but observationally, they say pomegranate juice is good, the hibiscus tea is good, choco is good, green tea is good. They have mentioned in the International Hypertension Guidelines. I was wondering, then I went through the pomegranate. They say it also, blocks ACE inhibitor receptors and all that. The pomegranate, there was a lot of studies. So instead of going for nutraceuticals, go for natural, and that will be good also.
That's a very good message, sir. So at the end, sir, there was again a common question which has come from Dr. Akhil Contractor, sir, also. So what message you would like to give it to our delegates, including what are the red flag signs that a family physician should know when they are managing a patient of hypertension, that this is the time now they should refer to a consultant. So your final take-home message, sir.
Okay. Final take-home message for all my friends, brothers and sisters. Whenever somebody comes to you for any reason, it can be toothache, it can be fever, it can be injury in the little finger. Make it a habit to check the blood pressure. Always you check the blood pressure. Don't allow your staff to check the blood pressure. For any reason they come, you check the blood pressure and make a note of it. Number two, always have 2-3 BP monitors. In our practice, I met one of the person. He said, this BP apparatus is given by my father. And he's still holding it. I said, keep it in the cupboard. When you see that, there was a 0 error. So they did not do validation. And everybody has got only one cuff. Please, today, when you go home, buy 3 cuffs, 3 different sizes of the cuff. It should cover 80 centimeters or 80% of your arm, the cuff. Suppose if you are an obese person comes, you cannot check the blood pressure with the normal size cuff. If somebody is thin, patala atmi come, you cannot correctly diagnose. The accurate measurement of blood pressure is key, where you will have to take all precautions. They should not have smoked half an hour back. They should not have coffee. They should sit quietly. Especially now, no mobile phone. Either the doctor or the patient when they do check. And then if they have an urge to pass urine, they should not check the pressure. So accurate blood pressure measurement is the key. Buy 3 cuffs. After all, 1 cuff may cost only 200-300 rupees. Have 3 cuffs. After all, this is your bread. You are spending only maybe 2,000 rupees. And somebody asked me how to do validation. In Mumbai, it's not easy. It's not a problem. But for a person like me in a small town, to send the BP apparatus to Bombay or Delhi or Calcutta or Chennai, it costs much. So he says, well, how do I do validation? I asked him a simple question. Sir, tell me what car you are having. He said, I have a Maruti car. And how often you change the car? He told me 3 years once I change the car. Why you want to change the car? Because after 3 years, you'll start giving trouble. So I don't want trouble. So I want to dispose. So when you can spend 6 lakhs rupees in 3 years, after all, this BP apparatus is only 2,000 rupees. Why don't you buy every year instead of going for validation? Buy every year. After all, it's not a big thing. You are changing the mobile phone every year. Why don't you? This is giving bread. This is your master. So buy BP monitors, buy 3 cups, and make sure there is no zero error. And then when you get a patient who has got problems like complications, like they have wheezing, or if they have pulmonary edema, if they have some signs of paralysis, if they have TIA, if they have some conditions which you cannot manage, it is always high time that you should send to the nearby hypertension specialist. So warning signs are when they have acute chest pain, it may be dissecting aneurysm or myocardial infarction. If they have some renal problem, like if they have puffiness of the face, or if the edema of the feet, and if they have any signs of neurological deficit, that's the time when the blood pressure is more than 120, 180, 110. When after all your regular treatment, still they 180, 110. When after all your regular treatment, still they continue to have, please send them for admission. Please send them to a hypertension specialist. So I make an appeal to Ketan. Please promote hypertension specialist in Mumbai. I want at least people like you to become a hypertension specialist. There you have 3 or 4 of your people join together. One neurologist, one nephrologist, one endocrinologist join together and form a group practice called Hypertension Special Center. So when it comes to you, you call the nephrologist for second opinion. You call the neurologist for any opinion, endocrinologist for some opinion. So it becomes an institute of hypertension, hypertension clinic, and hypertension specialist. This is my aim and ambition. I had been preaching for the last 4 years. I'm able to convince many people. And unlike diabetologists who are very good in convincing and making sure so many people are developing in diabetology specialists, hypertension specialists are not there. So we say send them to hypertension specialists. People are asking me, where is hypertension specialist here? So I think somebody who focuses only on hypertension and hypertension only, like diabetes means only diabetes they do. They do diabetic foot, they do diabetic eye, they do diabetic pregnancy. There is no such person called hypertension pregnancy, because hypertension pregnancy, hypertension disorders in pregnancy is more. I call it as HIPSI. There is a DIPSI association. There is no HIPSI association. So my message is focus on hypertension, and especially practitioners try to learn hypertension day in and day out. And I have got 3 WhatsApp group on hypertension. Group 1, Group 2, Group 3. All the 3 groups are filled now. And every day they ask so many fantastic questions which sometimes we cannot answer. So many unanswered questions are there. So I want to focus on hypertension. I'm conducting 10 webinars first course, then again another 10 webinars follow advanced course for the practitioners and physicians. I want everybody to focus on hypertension, and then you buy a fundus ophthalmoscope. Even the general practitioners start learning how to look for papillary edema, any AV changes, and then you also start looking for if there is a urine albuminuria. We don't say nowadays microalbuminuria. The terminology is now not there. Urine albuminuria they have. Then you do ECG and then see if you can do echo. So learn all that, and then you focus on hypertension and hypertension clinic, and join together with your colleagues and make sure you have got hypertension center and institute of hypertension and excellence for hypertension. We want more papers, and whatever you come across, write down, document whatever BP you come across. Suppose you come across 100 people this month, and then load down. You can get a clue. This group of people, because they take salt, they get the hypertension. These people are getting hypertension. The IT people, how many are there? So do a research, document. That'd be good. This is a column for artificial intelligence. But before artificial intelligence, we should be intelligent enough to do all that and make sure this hypertension is spread all over. And I want everybody to have some idea on hypertension. Obstetrician, surgeon, everybody, because before surgery, they should know what hypertension, because the burden of hypertension is much more than the burden of diabetes. So my message is make everybody focusing in hypertension. That's my message.
Fantastic, sir. You have conveyed in summary, everything, all salient points about the hypertension. And really, we are so much thankful to you for enlightening all our delegates on the subject of hypertension. Now, before I hand over to the IMA chapter, may I request Harish from InnoCare to say their word of thanks. Harish from InnoCare. Yeah.
Thank you so much, sir. Good evening, Professor Dr. Ketan Mehta, and good evening, Professor Dr. A. Muruganathan, and good evening, all the participants. Myself, Harish Mehta, working as a marketing manager in the InnoCare Life Sciences Company, and this entire webinar is organized by InnoCare Life Sciences Private Limited with the help of IMA Mumbai West. So just give you a brief idea about the company, sir. Like InnoCare Life Sciences is almost like 5 years old Mumbai-based company. And in InnoCare, more than 400 field people are working. We are operating across all India. InnoCare Life Sciences is known for innovation and innovative products. And we are the makers of T3, D3. We are makers of TendoShot. We are makers of T3 as well as InnoGold. So this T3, D3, which contains a tocotrienol, which is an advanced form of the vitamin E, which having almost 40 times more powerful antioxidant property as compared to plain vitamin E. Apart from the tocotrienols, we are giving vitamin D3 in our brand called the T3, D3, which contains 2000 international units of vitamin D3.
Now,
yes,
anxiolytic agents, tranquilizers have been now not recommended.
Okay, so just apart from this, sir, we are also giving vitamin B6 1.5 milligram, methylcobalamin 1500 microgram, and with a combination of L-methylfolate. So overall, there is one small study has been conducted in almost like 75 patients with the tocotrienols. This tocotrienols helps to reduce after 3 months. The tocotrienols reduces.
Just put a finger up and I will not call.
Okay, more than 15% tocotrienol helps to reduce the total cholesterol, helps to reduce LDL level, and also it reduces the triglyceride layer. Apart from this, T3, D3 can also be prescribed in the metabolic condition which are associated with the diabetes, and this tocotrienol, which regulates the PPR genes, improves the glucose utilization, also improves the insulin sensitivity. Second brand, we have a TendoShot, which can also be prescribed in a statin-induced tendinopathy cases, which itself contains a unique combination of curcumin. Also, it contains vitamin D3, which tackles pain, relax muscles, and improves the mobility in all your tendinitis and tendinosis patients.
Thank you, my Akhil.
From entire InnoCare Life Sciences, we would like to say thank you so much, Dr. A. Muruganathan and Dr. Ketan Mehta, for giving a valuable information and insights which is related to unanswered question in hypertension for family physician. Thank you so much, sir. Over to you.
Thank you, Harish. And may I request Dr. Akhil Contractor to give final vote of thanks?
Ketan, somebody in the message they asked me the webinar series link. So if I give the link to you, can you pass it to your group?
Yes, sir. Within 1 hour, we will give you a link, sir. YouTube link is there. We will give it to you, sir.
Absolutely, sir.
No, not. They are asking about hypertension webinar series.
Yes.
Okay.
And also our WhatsApp group link also. Yeah.
Correct. Fine. So you can give it.
We will see some of the messages they are asking.
Absolutely. Fine. Sir. And Dr. Akhil Bhai for final vote of thanks.
On behalf of IMA Mumbai West, we thank Dr. Ketan Mehta and Dr. Professor Muruganathan for giving an excellent talk on unanswered questions in hypertension. It was really very useful, I think, and everybody will probably gain. And as Dr. Muruganathan said, we have to really do something to see that hypertension specialists are in every city in India. We thank our sponsors for today, InnovaCare, for all the help. We thank all our delegates who have attended. In more than 100 have attended today, and we are really thankful to them, and of course all the support from Mr. Harish Bhai. Thank you very much, and we'll meet again on Tuesday. Thank you.
Thank you so much. Thank you, sir.
Thank you, Ketan. Thank you, Akhil. Thank you, Rashmikant.
Thank you.
Yeah, thank you.